and thank you everyone for joining us today. I, Amit Saxena, along with my teammates from Medical Services, Dr. Deepika Chawda, are delighted to welcome you all for today's webinar on adenomyosis under the aegis of AOGD and ISOPARB Delhi Chapter in collaboration with Sir Ganga Ram Hospital, New Delhi, and academic partner Jagsonpal Pharma Ltd, makers of EndoReg, CycloReg CR and Yuliprist. Today's discussion are brought to you by Jagsonpal Pharma Ltd, makers of EndoReg containing Dynogest 2 mg tablet, Yuliprist, a brand of ulipristal acetate, and CycloReg CR 10 mg containing norethisterone's control release tablet. A warm and hearty welcome to esteemed experts and all the attendees. Dear attendees, we request you to post your requirements, your questions, suggestions, clarifications by text in Q&A box. Please note this webinar is streaming live on Facebook and the link has already been shared on the chat box. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. As we initiate today's sessions, we request Coordinator Dr. Mala Srivastava, Senior Consultant and Professor Gripmar, Gynae Endoscopic and Robotics Surgeon, Sir Ganga Ram Hospital, New Delhi, Vice President-elect ISOPARB 2023-24 and past President AOGD 2021 to kindly initiate this session.
Thanks, Mr. Amit. Good evening, everyone. It's my pleasure and privilege to invite you all this evening for this session on adenomyosis, organized by Institute of Obs and Gynae, Sir Ganga Ram Hospital under the aegis of AOGD and ISOPARB Delhi Chapter. This evening session has been powered by none other than Dr. Asha Rao, who is the Chairperson of the Endometriosis Committee of FOGSI, together with stalwarts like Dr. Padma Shri, who is the Senior Sonologist from Coimbatore, Dr. Punita Bhardwaj, who is the prized endoscopic surgeon of Institute of Obs and Gynae, Sir Ganga Ram Hospital, and Dr. Neeti, who is the vibrating young IVF specialist from Ganga Ram Hospital. We have the blessings of ISOPARB President, Dr. Gangadhar Sahoo, and FOGSI Vice President, Dr. Ragini Agarwal. We have the presence of elite chairpersons like Dr. Gujral, Dr. Deepti Goswami, Dr. Harsha Khullar, Dr. Richa Sharma, Dr. Chandra Mansukhani, Dr. Manju Khemani, Dr. Sunita Kumar, all are experts in their own field. First of all, I request our President ISOPARB, Dr. Gangadhar Sahoo, to address the gathering. Sir is a great academician and he ensures that all ISOPARBian walk the talk. We do the work more than and do the less of talking. And we spend at least 15 minutes every day for the purpose of ISOPARB, serving and propagating the academic activities of ISOPARB. Sir is a retired professor and HOD, VSS Medical College, Burla, Dean, IMS and some hospital and Pro-Vice President, SOA. His dream is to be a leader of success for others to climb up, an ordinary man surrounded by extraordinary friends. And he is a well-wisher for all ISOPARBian. Sir, we want to have pearls of wisdom from you so that we are all enthusiastic, become enthusiastic and encouraged. Over to you, sir, for your pearls of wisdom.
Thank you, Mala. So my namaskar to you and all the esteemed guests, speakers, chairpersons and attendees. My best wishes from all my members of ISOPARB and FOGSI Odisha, and greetings, blessings from Lord Jagannath, who is now on the Ratha Jatra, starting from Sri Mandir. Now she is in Mahusima Mandir. So blessings from Lord Jagannath, Balabhadra and Ma Subhadra to all of you. So it is a nice meeting to all these stalwarts of Delhi and particularly of Sri Ganga Ram Hospital, and to discuss about a topic which is always controversial, whether medicine, surgery. Now we are talking about surgical, it is, somebody says. So to talk about this by such very, very esteemed speakers and chaired by many stalwarts. So as ISOPARB and as the president of ISOPARB, this year, as Dr. Mala has said, we have decided or chosen this theme as let us walk the talk. So walk more, talk less. Very correctly, she has remembered that you just give 15 minutes of your 24 hours towards ISOPARB and you will see a ISOPARB of a different shape. So with that objective, we are starting this year. So everywhere there is new enthusiasm, new chapters are coming up. Many members are voluntarily joining ISOPARB. And to start with, Delhi is one of the champions in the field of ISOPARB. So
hello, Ragini ma'am. Good evening.
Day in and day out.
Hello, Mala ma'am.
Hello.
The academics are going on. So once again, I thank Dr. Mala and her team to invite me for this webinar as the chief guest. I'll very you. So thank you everybody. Wish that this academic meet will be very interactive and successful. Thank you, madam. Thank you very much. Wish you all the best.
Thanks, sir.
I'm trying to unmute, but I
words.
think I'm getting muted all the time.
It's my pleasure to invite our guest of honor, Dr. Ragini Agarwal. Madam is a dynamic and charming vice president of Foxy, very energetic, enthusiastic, and always ready to help all of us. Madam has been IMA Haryana Chairperson for Academics and Public Health Education, President Indian Academy of Cosmetic Dermatology and Gynecology, Founder Gurugram OB-GYN Society, Founder President Association of Obstetrics and Gynecology of Haryana, Founder Committee Chairperson Aesthetic Health India. Madam, we are waiting to hear from you from Pearls of Wisdom for this evening.
Thank you so much, Mala, for this honor, and my respect to all the seniors and the stalwarts from the Delhi who are going to chair, and all the great speaker what you have chosen for today. I'm not going to take the name of each and everyone. I'm seeing there almost 100 participants are there who are really waiting to listen the speakers, not me. So I just say the topic is very, very apt, and adenomyosis is always a controversy and always really a big dilemma how to treat. And specifically when a woman of 35, 40 comes with adenomyosis, what type of the operation or what type of the medicine we are going to give them? Because we all know that conservative operation is not going to get benefited and we cannot operate a patient. I think a medical management, if there's something is really a boon, so we will listen all of you and really help our patient. Thank you so much, and I wish you a very, very best and all the participants to have a happy learning. Thank you so much. Over to you, Mala.
Thanks, ma'am, for your encouraging words. Now we move on to the scientific session. Our Master of Ceremony, Dr. Huma Qureshi, she is the Associate Consultant, Institute of Obs and Gynae, Sir Ganga Ram Hospital. She is going to take the scientific program further. To invite the chairpersons of the first session, I think she's not been able to join. It's my pleasure to introduce the chairpersons of the first session. Chairpersons for the first session is Dr. Gujral. Madam is the chairperson, Institute of Obs and Gynae, Sir Ganga Ram Hospital, and she is the in charge of the high-risk pregnancy clinic, past president of NARCHI. Also, she has been the past president of DGF Central Delhi, past vice president of AOGD NARCHI, past joint secretary, Indian Menopause Society. Madam is very, very academically oriented, and she always encouraged the entire department in the academics, in the clinics, everywhere. Our second chairperson is Dr. Deepti Goswami. Madam is Director Professor and Unit Head Department of Obs and Gynae, Maulana Azad Medical College, New Delhi. And she is also the Honorary Secretary of AOGD this year. She has the Commonwealth Scholarship and she is the Nodal Officer of Maternal Death Review. Over to you to carry on the first session. It's my request to the chairpersons to carry on the first session.
My pleasure to introduce the first speaker, Dr. Neeti Tiwari, a brilliant IVF consultant. She speaks as well as she looks. Let's hear her to speak on pathophysiology of adenomyosis. Dr. Neeti Tiwari, all yours. You taught me a lot today, Neeti.
Thank you, ma'am. Thank you for the kind introduction. Respected chairpersons, seniors, and my dear friends, first of all, I would like to thank you, Dr. Mala, for giving me this topic to speak, because we all keep talking about medical management, surgical management, but she gave me an opportunity to go back to my basics and study about pathogenesis and mechanism of adenomyosis, because I realized how important it is to know the basics so as to understand the symptomatology and what newer therapeutic options are available in the field of adenomyosis. So we know that adenomyosis is defined as the presence of endometrial stroma and glands within the myometrium, at least one low power field from the base of endometrium. So there is a presence of endometrial gland and stroma within the myometrium 2.5 millimeter from endomyometrial junction, accompanied by smooth muscle hyperplasia. So what is unique about uterus is that otherwise in mucosal organs like intestines, there is always a basement membrane between the endothelium and the muscularis layer. But in the uterus, this layer is missing. So basically, the endometrium is in continuity with the myometrium. And maybe that also predisposes to the pathogenesis of the adenomyosis. So all the problem starts in the junctional zone. We know the junctional zone on MRI was described as a low signal intensity zone in between the high signal intensity endometrial stripe and an intermediate signal intensity of outer myometrium. And actually, the myometrium of the uterus is actually divided into inner myometrium and outer myometrium. And though histopathologically they may appear the same, but embryologically they are different. The inner myometrium has been derived from the Mullerian duct, whereas along with the endometrium, whereas the outer myometrium is derived from the mesenchymal layer. So their characteristics is also different. The inner myometrium, the junctional zone, is basically irregularly arranged fibers, circular, whereas the outer myometrium is regularly arranged and longitudinal fiber. And adenomyosis, the entire problem start in this endomyometrial junction. So the incidence of adenomyosis would never be known because so many times it goes unreported. But in histological reports after hysterectomy, 10% to 35% of specimens show it. Data from ultrasound units, 20.9%. And women undergoing assisted reproductive technology, 20% to 25% of women have adenomyosis. And whereas the risk factor goes, we know that it is a disease of 40 to 45 years, 80% of the cases actually occur in this age group, but now we are seeing more towards the younger population. Multiparity is a risk factor, prior uterine surgery is a risk factor, smoking is a risk factor for both endometriosis as well as adenomyosis and endometrial hyperplasia. So we call adenomyosis focal if more than 25% of the circumference of the lesion is surrounded by normal myometrium, whereas we call it diffuse when less than 25% of the lesion is surrounded by a normal myometrium. And when the entire lesion is surrounded by a normal myometrium, we call it adenomyoma. And it is also called cystic when there are presence of measurable myometrial cysts, and non-cystic when we can't see them on ultrasound or MRIs. So coming to the mechanism of adenomyosis, so 4 theories have been given. First is invasion of endometrial basalis into the myometrium, then microtrauma of junctional zone induced by tissue injury and repair, de novo metaplasia from stem cells, and outside to inside invasion induced by retrograde menstruation. So let's see what these mechanisms are one by one. So invasion of endometrial basalis into the myometrium, basically it's based on endomyometrial interface which is breached, which is injured. And this injury could be because of repeated sharp endometrial curettage, cesarean delivery, or prior uterine surgery. And on the background of this injury are altered endometrial basalis cells, which invade into the myometrium, crossing an injured junctional zone. So all this is characterized by an enhanced endometrial cell migration. These cells have acquired an invasive property. They are altered and they have acquired an invasive property, and they are able to invade through the injured EMI, the endomyometrial interface. Then epithelial to mesenchymal transition, which happens. Then these cells, when they enter the myometrium, they start proliferating, and they are also resistant to apoptosis because of various anti-apoptotic factors they acquire. And then there is a dysregulation of the extracellular matrix. There's a dysregulation of extracellular matrix, and because of various matrix metalloproteinases which are overexpressed, like MMP2 and 9. So this is the invasion of endometrial basalis into myometrium. It easily explains the occurrence of adenomyosis in women who had prior surgery or uterine injury in any form. But what about women who were actually nulliparous or never had any uterine surgery and still have adenomyosis? So the second theory, which is the microtrauma of endometrial myometrial interface, which is called autotraumatization, now explains this. So what happens is that in every natural menstrual cycle, there are peristaltic activity. It has been described very clearly that there is a peristaltic activity which happens in the endomyometrial interface. So because of this peristaltic activities, there will be slight tissue injury and repair, which is called TR. Now this tissue injury initiates interleukin-1, which activates cyclooxygenase 2, and which leads to production of prostaglandin E2, and all this jargon in the end, it leads to activation of steroidogenic acute regulatory protein STAR and P450 aromatase. And what does this do? This leads to increased formation of testosterone and aromatization to estradiol. So this makes the the local environment hyperestrogenic. This local hyperestrogenic environment is actually meant to, in a normal woman, is actually meant to heal whatever tissue injury happens because of the peristalsis. But in women with endometriosis, there is an increased local estradiol in utopic endometrium, which stimulate hyperperistalsis. So it is not normal peristalsis, it is hyperperistalsis in this endometrial myometrial interface or the junctional zone through the endometrial receptor alpha and oxytocin. And this imposes supraphysiological strain on myocyte. It tears the myocyte and it keeps on happening, leading to continuous microtrauma. So because of this, and because in the presence of estradiol, there is an endometrial proliferation also. So through this, injured endometrial myometrial interface, the proliferated cells, they move inside. So in this, flow diagram, I have kind of, it explains it very well. So it is basically increased estradiol at the center, which is because of increased conversion of testosterone to estradiol and decreased metabolism of estradiol. So the concentration of estradiol increases, which through estradiol receptor beta leads to endometrial proliferation, and through estrogen receptor alpha leads to hyperperistalsis, and all this leads to endometrial invagination. And this hyperperistalsis also initiates the TR mechanism, which I talked about, which through all this cascade finally leads to increased testosterone, increased conversion of testosterone to estradiol, and a hyperestrogenic environment. So which keeps on, like a vicious cycle, keeps on tearing the EMI, traumatizing it, and the cells keep on going inside. The other theory now, the third theory, was basically, came out to explain the adenomyosis lesions which were reported in the myometrium of the Rokitansky-Kuster-Hauser syndrome patients who actually lacked a functional endometrium. So it was thought that how can they, develop adenomyosis? So the de novo metaplasia theory came in, wherein it was said that there could be embryonic stem cells from the Mullerian duct, which during Mullerian duct development and fusion, some remnants of the embryonic tissue, it remains, and then it gets misplaced in the myometrium, giving rise to adenomyosis. Even the adult stem cells, which are there in the basalis layers, sometimes when the injury happens to the EMI, the endomyometrial interface, they can travel inside and then proliferate and differentiate into adenomyotic lesion. And then the fourth theory was outside to inside invasion, something which we give always for the endometriosis. So basically menstrual blood carrying the adult stem cells from the epithelial and stromal component of the endometrium, they basically come inside the peritoneum, and then from there they breach the uterine serosa. They're able to breach the uterine serosa, and then they harvest in the outer myometrium of the uterus. So this theory basically explains the high prevalence of posterior focal adenomyosis of the outer myometrium. How does adenomyosis happens in the outer myometrium can be explained by this theory. So all these mechanisms were given, and basically all these mechanisms, finally lead to development of adenomyosis, but the center is hyperestrogenism and a progesterone resistance which is there. Why progesterone resistance? Because normally if the estrogen is high, progesterone is able to counteract it. But in cases of adenomyosis, it is not counteracted because there is a resistance at the level of progesterone receptors. So the hyperestrogenism is able to have its way through the uterus. So this, there are other factors which are able to, which are important in the pathogenesis of adenomyosis. There are various genetic and epigenetic factors. There are so many of them. I couldn't bring out, all the factors in this small time, but these factors basically, they promote hyperestrogenism and progesterone resistance. They promote cell proliferation, migration of the cells into the myometrium, and invasiveness of endometrial cellular compartment. Then there are pituitary hormones also, like oxytocin and prolactin. Oxytocin basically act via hyperestrogenism only, that they cause hyperperistalsis and promote adenomyosis. Prolactin, it has been seen that hyperprolactinemia is also associated with adenomyosis, though the correlation is not very clear. And then there are environmental factors also, like endocrine disrupting chemicals like phthalates, which have been implicated in the pathogenesis of adenomyosis. So what all these finally, which they are doing is, there is angiogenesis. There is angiogenesis, VEGF, activin, thrombin are overexpressed. There is inflammation, because of which prostaglandins, COX-2, tumor necrotic factor, all these are overexpressed. Then there is a neurogenesis. That because of which their nerve growth factor and syntropin, all these molecules are overexpressed. And then there is fibrosis. And all this finally leads to pain, heavy menstrual bleeding, and infertility. So there are associated pathologies with adenomyosis. Most common, we know that it is leiomyoma. Then pelvic endometriosis. It is also associated with endometrial polyps and endometrial hyperplasias. So coming to the clinical presentation, there would be some lucky ladies who will, with adenomyosis, will remain asymptomatic. Otherwise, abnormal uterine bleeding is the most frequent symptom in case of diffuse adenomyosis in the internal myometrium. Whereas when it is in the external myometrium focal adenomyosis, it is mostly associated with infertility. Pelvic pain in the form of dysmenorrhea, non-cyclical pelvic pain, dyspareunia, dyschezia is seen with deep this thing with adenomyosis with deep endometriosis. Then coming to the mechanism underlying the pelvic pain, the intensity of pain correlates with the depth of the lesion, but there are various factors which contribute to the pelvic pain. First is myometrial hypercontractility and increased contractile amplitude of the uterine smooth muscles, which leads to pelvic pain. Then there are numerous inflammatory mediators are aberrantly expressed. There is increased expression of interleukin 1, interleukin 18, tumor necrotic factor alpha, COX-2, and prostaglandin E2 synthesis is increased. And because of these inflammatory mediators, there is pelvic pain. And here comes the roles of giving NSAIDs in these patients. Then there is a neuropathic nature of this pain, which is there in adenomyosis. And this is because of the underlying neurogenesis. There is basically a plexus, a neural plexus, which is there subserosal. And this in this plexus is is supposed to, is supposed to for the sensitivity of the uterus, and there is heightened sensitivity. The uterine pain perception is heightened because of increased expression of the neurogenic factors, which I talked about, the nerve growth factors and the syntropin. And because of this, the pain of adenomyosis is very typical characteristic, and it is a very heightened uterine pain perception. Then coming to the heavy menstrual bleeding, it is the most common symptom with which the women come. And then there are again various factors which contribute to this. First of all, abnormal uterine contractility, then increased expression of pro-angiogenic factors like vascular endothelial growth factor, which is triggered by tissue injury and repair, which I talked about, hypoxia and hormonal dysregulation, which is seen in adenomyosis. Then there is a higher expression of endothelial nitric oxide synthase in the endometrium and myometrium, which can also lead to vasodilatation and further heavy menstrual bleeding. So these women will present with, when we examine them, there is a uterus which is mobile but tender, diffusely enlarged, soft, and rarely exceeds the size of a pregnant uterus at 12 weeks of gestation. And if you find a uterus which is adherent, it is usually because of the concomitant endometriosis associated with it. Coming to adenomyosis and infertility, so there are a lot of factors in adenomyosis which can lead to infertility. First of all, the abnormal uterotubal transport. There is intrauterine abnormalities, adenomyoma that distort the uterine cavity, may obstruct the tubal ostia physically and interfere with sperm migration and embryo transport. There could be a disturbed uterine peristalsis and sperm transport, and there can be destruction of normal myometrial architecture and function. Then there is a poor endometrial receptivity because of aberrant endometrial metabolism in adenomyotic tissues and utopic endometrium of patients with adenomyosis. Implantation associated factors like HOXA10, LIF and MMP2 are dysregulated. And there is an altered uterine oxidative stress environment because of chronic inflammation which is happening. There is increased amount of reactive oxygen species, and all these make the endometrial receptivity poor. So basically, we know that adenomyosis, we consider it as an evil cousin, evil sister of endometriosis, because endometriosis can still be dealt, surgically, and things can be made good for, from fertility point of view. I being a fertility specialist, if you tell me to choose between endometriosis and adenomyosis, I will always choose endometriosis, because adenomyosis actually it affects the uterine receptivity in a big way because it is associated with chronic inflammation, dysregulation myometrial architecture, overexpression of endometrial P450. There are aberration of adhesion molecules, dysperistalsis, abnormal intramyometrial metabolism, and altered function of HOXA10 gene, which is very important for the endometrial receptivity. So the junctional zone abnormality due to adenomyosis, they are associated with lower implantation rates in IVF because of excessive inner myometrial contractions have been shown to reduce implantation rate. Inverse correlation between the frequency of uterine peristalsis on the day of embryo transfer and pregnancy outcome. So high frequency endometrial waves on the day of embryo transfers appear to affect the IVF ET outcome in a negative manner, possibly by expelling the embryos from the uterine cavity. And hence there is an emerging role, though it is not well established, of giving atosiban during the transfer when we do in the adenomyotic uterus. So to conclude, adenomyosis is an estrogen-dependent disorder resulting from one of the several mechanisms which I discussed. There are also genetic, epigenetic, environmental, and pituitary triggers. There is a central role of local hyperestrogenism, progesterone resistance, and chronic inflammation, along with abnormal uterine contractility and neuroangiogenesis, which leads to pelvic pain, heavy menstrual bleeding, and infertility. And this progesterone resistance, which is there, can sometimes, tell us about the why the patients are not responding to the progesterone treatment, which we keep on giving them to control their symptoms, because they could be progesterone resistant at the local level. Then this integrating emerging knowledge of mechanisms behind adenomyosis can help us develop targeted therapies in future to mitigate symptoms which still remain unresolved till date. We are still not got enough answers for complete, relief in adenomyosis, and maybe we can target these points where the mechanisms are working to resolve the symptoms. With this, I would end my talk. Thank you so much. Thank you.
Thank you, Dr. Neeti, for this excellent discussion. I think we have all learned a lot about the pathogenesis. In most of the forums, we see that we are discussing more of endometriosis, and even the undergraduates know about the pathogenesis and mechanisms. But it was very nice. You have discussed it so comprehensively, and I'm sure all of us have understood why we find a differential thickness of the posterior wall as compared to the anterior wall. You have given us a theory of outside to inside, why it happens and why it becomes so frustrating for the patient as well for the treating consultant, particularly the infertility persons, to manage women with these conditions. So I thank you for such and congratulate you for taking such a nice talk. We all have learned a lot. And I also congratulate Dr. Mala Srivastava for picking up such a niche area, which we see almost every day in our clinics. And many a times we feel frustrated and don't know what to do. Probably an insight into pathogenesis will help us tailor the treatment better, as well as those of us who think in terms of research can think of something in this area. Thank you very much.
Thank you, ma'am. Thank you for your kind words.
Well, Neeti, that was a very, very nice talk. As usual, you spoke very well. And they asked me to add expert comments. There's no expert comment on the pathogenesis. It is still not there, but I'd just like to give one or two small take-homes. We know the incidence is rising, possibly because our imaging modalities have increased. 35%, 40%, some have even quoted 60%, which is rather high. We also know that only a small minority of adenomyotics are going to be asymptomatic. Usually they are symptomatic, moderate to severe symptom, bleeding and pain being the most common ones. And you beautifully highlighted that the cause is neurogenesis, angiogenesis, and the contracture abnormalities of the uterus. I like the way you said, you explained the association with infertility and, IVF success, and you chose the less evil sister, that is the endometriosis. I like that, and that is true. Adenomyosis just can't do a thing. May it be the treatment, may it be they often fail in pregnancy. So I understand as an IVF specialist, you'd prefer endometriosis. Somebody will evacuate for you, treat the endometriosis, and then you can give her eggs and the uterus is normal for conception. Also that the 25% criteria of focal, diffuse, and adenomyoma very nicely explained, beautiful diagrams. And as Dipti said, pathophysiology, we are trying to understand, it is still presumptive, whether it's a microtrauma of the junctional zone, whether it's a retrograde menstruation, whether it's a stem cell metaplasia, local hyperestrogenic, less progesterone. You really explained it so beautifully. Then genetic, epigenetic, modifications, and even the role of some pituitary hormones. And we said that etossiban can be given. I really didn't know unless you told me that etossiban you're using for adenomyosis. Anyway, that's a very beautiful summary. And the problem now happens, how do we treat? And we have the next 2 sessions on the medical and surgical management. Once again, congratulate you, Neeti, for a very, very good talk.
Thank you, ma'am. Thank you.
Simple, made it simple, a very difficult topic, and lovely diagrams wherever you got the pictures from. We hand over to the next chairperson, please.
Good evening, everyone. So after an amazing and enlightening session by Dr. Neeti Tiwari, we move on to our second session, which is on imaging in decoding adenomyosis. For that, I would like to call upon the chairpersons. Dr. Harsha Kullar, ma'am is the vice chairperson of the Institute of Obs and Gynae, Sir Ganga Ram Hospital. Ma'am has got special interest in oncology, and ma'am has been working as a senior consultant in Institutes of Obs and Gynae since 1988. She had been secretary of AOGD, ex-joint secretary of IMS, NARCHI, and the second chairperson for today is Dr. Richa Sharma. So ma'am is a professor in GTB Hospital. Ma'am is the chairperson of MTP committee by Foxy. Ma'am has got many accomplishments in her pocket. Ma'am is AOGD skill and workshop coordinator. Ma'am is endoscopy committee chairperson from 2019 to 2021 and joint secretary of IAG Delhi Chapter. She is the organizing chairperson of AOGD pre-Congress endoscopy live workshop and Foxy fertility enhancing endoscopy workshop in 2019. So over to you, ma'am, for the next session.
Okay, thank you so much for the kind introduction. So a very good evening, everybody. And first of all, I thank Dr. Mala Srivastava ma'am for inviting me and organizing this wonderful webinar. So now it is my privilege to invite our speaker, Dr. G. Padamshri. She is a sonologist at Rao Hospital, Coimbatore since 28 years. And she is one of the key members of ART team, Rao Hospital. And she has presented poster on Momo twins in IFFS Germany 2010 and presented poster on 3D ultrasound in power Doppler in prediction of IVF outcome, ASHRAE 2015. So we welcome Dr. G. Padamshri, and she will be speaking on imaging and decoding adenomyosis. So over to you.
First of all, I would like to thank the organizers and Dr. Mala Srivastava and Dr. Asha Rao for giving an opportunity to talk on imaging in decoding adenomyosis. It's no more a disease of 40 years old multiparous who present only with menorrhagia and pain. More and more, we are seeing it in young women who not only present with pain and AUB, but they also present with infertility. And 1/3 of adenomyotic patients are totally asymptomatic. So the diagnosis becomes all the more crucial. As we know that adenomyosis is associated with previous ART failures in 34.7% of the cases and 38.2% of RPL, and it is associated with endometriosis in 35.1% and with DIE in 50% of the cases. So uniform diagnostic criteria is essential for standardizing the techniques by ultrasound. As we all know, you can see the 3D image. This is a coronal view where you can see the normal uterus with a well-defined cavity. So in case of adenomyosis, there is endometrial glandular infiltration across the myometrium, resulting in myohypoplasia and hypertrophy and areas of hemorrhage, altering the entire echo texture. You can see the normal myometrial tissue is only pushed to the eccentric position. So these pathological features can be brought out well by sonographic signs. Let us see the sonographic signs which help us as tools to identify adenomyosis. First is the heterogeneous myometrium. When you see the uterus, just see whether it is normal or enlarged uterus. Here you can see the enlarged uterus. Then look at the myometrium. See whether it's ill-defined or well-defined. You can see the ill-defined heterogeneous myometrium here. And then when you here you can see the endometrial glands, which are depicted as linear striations, and hypoechoic area is depicted as a myohypoplasia. You can see the linear striations extending across from the inner myometrium to the serosa. This is typically a Swiss cheese or rainforest appearance. So whenever you see a heterogeneous echogenicity and rainforest appearance, think of adenomyosis. And the second sonographic sign is asymmetry. In case of adenomyosis, there is thickening of the myometrium is happening, and you can see the anterior myometrium. Obviously, it is thickened. So it is better to quantify the thickness of the myometrium. So if the ratio between the two is more than 1, that goes in favor of asymmetry. Again, it's an indicator of adenomyosis. And wherever the endometrial gland, it shows us as echogenic area. Here you can see the echogenic spots, again another marker, because the endometrial gland extends into the endomyometrial surface, giving the echogenic spots. So when it multiplies, it gives like a echogenic buds. So this is a 3D HD-like image where you can see the echogenic buds here. So echogenic spots and endometrial buds, if you identify, these are the sonographic signs of adenomyosis. Next sign is the myometrial cyst. Whenever you see an anechoic space in the myometrium, think of myometrial cyst. And you can, in case of doubt, you can decrease the depth and zoom in on to enlarge the field. And typically, the myometrial cyst will be circumscribed by the echogenic rim. And you can look for the content also. So whenever you see the myometrial cyst, identify the number of the cyst, diameter of the cyst, and also the location of the cyst. And if you have any doubt, switch on the Doppler, and so to rule out any blood vessel. So next sign is the hyperechogenic islands. Here you can see the area of adenomyosis. So when the endometrial gland forms aggregates, it gives us a nodule-like appearance. So these are called islands. And again, you can see the islands of endometrial glands here, and 3D image beautifully showing the number of echogenic islands here. And here, this is a severe form of adenomyosis where all the sonographic signs are there. Here you can see the islets of endometrial tissues. This is a sonographic sign. And coming to the endomyometrial junction, normally you see the hypoechoic area around the endometrium. So this is a normal endomyometrial junction. But in case of adenomyosis, you can see the ill-defined endomyometrial junction, and there is infiltration of the endometrial glands across into the endomyometrial junction, giving an ill-defined endomyometrial junction. This is again another sonographic sign. In spite of, in case of adenomyosis, there is a fan-shaped shadowing. Whereas in case of myoma, because of the capsule, there is a H-shaped shadowing. This again is a differentiating point between myoma and adenomyosis. Coming to the role of Doppler in adenomyosis, you can see when you switch on the color flow, you can see the translesional vascularity in a case of large adenomyosis. But it's preferable to use a power Doppler because it can pick up even a low flow vessel, and characteristically in case of adenomyosis there is a dilated vessel with a branching pattern. So if you find such a translesional vascularity, it identifies adenomyosis. And again, to differentiate from a myoma will have a circumferential flow. So to differentiate between adenomyosis and leoma, adenomyosis will never have a well-defined margin. It will have an indistinct margin and all heterogeneous echogenicity with internal vascularity, whereas fibroid will well-defined margin, homogeneous, except in degeneration, you will see cystic areas with peripheral vascularity. In case of adenomyosis, the pathology is amid the myometrium. There is no compression of the myometrial tissue. Once you research, there is loss of myometrial tissue. This explains the complications that occurs like rupture uterus in case of pregnancy. But in case of a fibroid, it actually pushes the myometrium away and the myometrium is compressed. Once the myomectomy is done, it recovers and there is actually no loss of myometrial tissue. So we have seen the sonographic signs of 2D ultrasound, and heterogeneous myometrium carries a higher sensitivity. So if you see a heterogeneous myometrium, think of adenomyosis. More number of ultrasound features you detect, less will be the possibility of reproductive outcome. Marvelous et al. Says the pregnancy rate comes down from 42.7% to 22.9% if you identify 4 sonographic signs. But it again further comes down to 13% if you identify all 7 ultrasound features of adenomyosis. So it is important to know the sonographic signs and look for sonographic signs to detect adenomyosis. Coming to the types of adenomyosis, so this is a heterogeneous area in the posterior myometrium. What is focal adenomyosis? So if more than 25% of the lesion is covered by the normal myometrium, as you see it here, this is a focal adenomyosis, and you can see the normal myometrium. Whereas in the diffuse adenomyosis, less than 25% of the lesion is covered by the normal myometrium. This is a severe form of adenomyosis. Whenever you see adenomyosis, always take the largest diameter of the largest lesion. And again, you can see the extent of adenomyosis. It extends from the inner myometrium to the serosa. If more than 50% of the uterine volume is involved, that is called a severe adenomyosis. So this is a severe diffuse adenomyosis. Coming to the uterine layer involvement. Why should we pay so much attention whether it is focal or diffuse adenomyosis? Because you can see the large area of diffuse adenomyosis here. Negative impact of diffuse adenomyosis was more pronounced in diffuse adenomyosis rather than the focal adenomyosis. And again, diffuse adenomyosis is associated with dysmenorrhea and abnormal uterine bleeding. And as far as prevalence is concerned, diffuse adenomyosis is prevalent in 81% of the cases, whereas focal is prevalent in 18.3% of the cases. And if the largest lesion is more than 6 centimeters in case of a diffuse adenomyosis, there is always chance for second trimester miscarriage and cervical incompetency. And what is adenomyoma? In case of focal adenomyosis, if it is surrounded by the hypertrophied myometrium instead of the normal myometrium, it is called adenomyoma. And in case of adenomyosis, you can see the large lesion here, adenomyosis, enlarged uterus. And most of the time we can trace the cavity, it traverses through the lesion. This is a 3D coronal image. And whenever we identify adenomyosis, it is better to map the lesion, whether it is focal or multifocal, whether it's superficial or diffuse, whether it's symmetrical or asymmetrical, whether it's a solid, cystic, subserous, submucous, anterior or posterior. And coming to the location of adenomyosis, you can see the large diffuse adenomyosis here, but we can see the endometrial cavity and the anterior myometrium is totally normal. So this is a posterior adenomyosis. And again, this is a 3D rendered image. You can see the normal cavity. Cavity length is normal, but you can see the fundal region, it is occupied by the large adenomyosis. So 3D is very useful as far as locating the adenomyosis. And we have another advantage with the volume contrast imaging. When you apply VCI, then you can see the right lateral wall involvement of the adenomyosis, a large adenomyosis pushing the cavity to the one side. And again, this is a 3D image. You can see the adenomyotic nodule partly inside and partly involving the serosa. So 3D is very useful for locating the adenomyosis. And it can present as adenomyotic cyst also. You can see the adenomyotic cyst in the myometrium. It has a specifically echogenic rim. And if in case of a doubt, you apply the probe pressure over the cervix, and the ovarian cyst will show positive splitting sign, unlike adenomyotic cyst. And here you can see the adenomyotic cyst well capsulated with a lot of internal hemorrhage. So once identified, excision will be beneficial. In most of the cases, adenomyosis is associated with a thickened endometrium. You can see the anterior myometrium showing thickened, diffuse adenomyosis, and there is a thickened, ill-defined endomyometrial junction also. When you switch on the 3D, you can see the polypoidal adenomyosis inside the cavity. Generally, they are heterogeneous polypoidal with cystic spaces. You can see the endometrial buds. So this is a case of adenomyosis. Once you identify polypoidal adenomyosis by ultrasound, you can subject them for hysteroscopic removal. And as said earlier, Chairperson et al. Described from outside to inside invasion theory, resulting in anterior form and posterior form. So whenever you see endometriotic cyst, you can see, always look for the myometrial involvement by adenomyosis, because there is migration across the serosa, and you can see the posterior myometrium with adenomyosis. This is posterior form. Whereas here you can see the inner myometrium is completely free, and you can see the myometriosis in the anteriorly. Maybe this could be due to serosal invasion from the vesicouterine pores. This is called anterior form. And next important sign for identifying adenomyosis is the question mark sign. Here you can see the question mark sign of the adenomyosis. This happens because you can see the endometriotic cyst here, and because of the involvement of the serosa and inflammation and adhesion, and the endometrial cavity is pulled back. So typically the presence of question mark sign is associated with presence of adenomyosis. And coming to the another type of adenomyosis, there is internal and external. Here you can see the endometrial cavity, but it is not well defined. You can see the irregularity of the junctional zone here. So this is called internal adenomyosis. Whereas here you can see the uterus here, and this is the endometrial cavity, but you can see the large adenomyotic nodule. Mostly it is a serosal involvement. This is called external adenomyosis. It can present as ACUM, that is accessory cavitated uterine mass. You can see the normal cavity, there is no sign of any adenomyosis, but you see a cystic lesion subserosally. This is not a fibroid because the content is cystic with internal echoes. And this is not associated with the congenital Mullerian anomaly, because you can see the most fascia together, and this is a normal uterine cavity, and this is a 3D rendered image where you see the cystic mass over the surface of the uterus anteriorly. And once laparoscopic excision was done, you can see the chocolate material pouring in. So this is a case of ACUM. And coming to the role of elastography in the diagnosis of adenomyosis. So as we all know, whenever there is a firm tissue, elastography gives a blue color. So in case of a fibroid, it contains firm tissue, it is a blue color. But in case of adenomyosis, it is of various varying echo texture. So you see varying level of colors like orange, yellow, and blue. So this carries higher sensitivity and specificity for diagnosing adenomyosis occur at all. Coming to the most important junctional zone and 3D ultrasound in identifying adenomyosis. Actually, the junctional zone serves as a missing link between reproductive disorders and major obstetrical disorders. So you can see the normal endomyometrial junction here, and this is a schematic representation. This is the endometrial cavity, and this is the junctional zone, and this is the area of infiltration by the adenomyosis by the endometrial glands. So junctional zone is hormone dependent and it governs reproductive function. We should understand the junctional zone varies with menstruation, and best time to visualize is 8 to 16th day. By applying deep learning and artificial intelligence, after taking a 3D sweep, it can automatically demarcate and delineate the junctional zone here. So maybe in the coming years, we will be seeing ultrasound machines incorporated with AI so that quantification of the junctional zone becomes much easier. And why do we care more about junction zone thickness? In this published European journal, it says if you compare with the control group, the junctional zone thickness is more, and it is an independent indicator of a higher risk of miscarriage. So how do we quantify the junction zone? So according to the 3D ultrasound criteria, you can take a 3D sweep and you can assess the junction zone in the anterior, posterior, and coronal view, and you can take the average. So you can see the maximum junction zone thickness and minimal junction zone thickness. So if the junction zone thickness is more than 8 millimeter, or if the difference is more than 4 millimeter, that goes in favor of adenomyosis, says Jagsonpal et al. And as said earlier, because of the tissue injury and repair, there is focal infiltration of endometrial glands across the endomyometrial junction. You can see the focal area of infiltration here. And here you can see the diffuse involvement of the junctional zone. And because of the defective spiral artery remodeling that is happening in the junctional zone, there is altered placentation, which is the basic cause for the possibility of SGA, increased risk of preterm birth, PROM, and PPH, etc. And more than the quantification of the junctional zone, morphological assessment will help us to assess the severity in identifying the adenomyosis. Instead of a well-defined cavity, you can see the irregular outline. So whenever you see an irregular outline, think of adenomyosis. And here interrupted, because one side looks normal, but the other side you can see the infiltration in the 3D image. Here it is completely obliterated. So once we identify the severity of the disease, we can counsel the patient regarding the possible outcome in these cases. So of the 3D ultrasound, if you identify poor definition junctional zone, in 87.8% cases, it is a case of adenomyosis. So if you compare between 2D and 3D, 3D has an edge over 2D because it has a sensitivity of 88.9% compared to 83.3% by TBS. And so far we have seen the application of ultrasound in identification of adenomyosis, and ultrasound is really helpful in the management part also. Here it's an interesting case where you see the initial enlarged uterus with diffuse adenomyosis with a volume of 149 cc. But after the medical treatment, even subjectively, you can realize the reduction in the volume of the uterus. So once the volume was reached 105 cc, that was the time Dr. Asha Rao did the embryo transfer, decided to go for embryo transfer, and she conceived a singleton and delivered at 38 weeks a healthy baby. So this substantiates the theory. It's a retrospective study by Ziaco et al. He says after GnRH analog suppression, the uterine volume is more than 98.8 cc. It is found to be associated with higher miscarriage with no difference in implantation rate. So we need sonographic classification and reporting system for diagnosing adenomyosis. So if you identify adenomyosis, always locate the adenomyosis, whether it's anterior, posterior, left lateral or right lateral, and differentiate whether it's a focal, diffuse or mixed. And also look for any cysts inside, and also look for the layer of involvement, and also the extent of adenomyosis, and also the size of the adenomyosis. Coming to the role of MRI, you can see the T1 weighted image showing low signal intensity, and junction zone thickness of more than 12 millimeter goes in favor of adenomyosis. Here you can see the T2 weighted image with a high intense signal depicting the area of focal hemorrhage. So if the junction zone thickness by MRI is less than 8 millimeter, it rules out adenomyosis. Between 8 to 12 millimeter, it is inconclusive. And again, you can see the Swiss cheese appearance, adenomatous polyp, and you can see the enhancement of the fibrous muscular components. But MRI can add information and increase diagnostic performance in difficult cases, especially when there is coexistence of lesions such as fibroids. In Champaneria et al. Did a systematic study to compare the diagnostic accuracy of MRI and ultrasound. It included 23 articles involving 2,312 women. It says TVS has a sensitivity of 72% and MRI had a pooled sensitivity of 77%. And they concluded that both TVS and MRI had high levels of accuracy in diagnosing adenomyosis. So to conclude, transvaginal sonography is the first test in the diagnosis of adenomyosis. Visualization of typical sonographic features will lead to lesion detection. 3D ultrasound evaluation of junctional zone for irregularity and infiltration can detect early adenomyosis. Both the high-end ultrasound machine and a high level of expertise will optimize diagnostic accuracy. Thank you for the patient hearing.
Thank you, Dr. Padamshri Madam, for your crisp and informative talk. You have really simplified imaging in adenomyosis very well, Madam. I just want to ask you which category of patient you go for 3D and 3D ultrasound or MRI, because by 2D with Doppler, majority of the cases we can pick up. So in your practice, when do you go for 3D or MRI? Which category of the patients?
So if it is associated with fibroids and if it is a very large uterus, then we advise MRI. Okay. And in case of 3D ultrasound, we can pick up early cases like junction zone alteration, like irregularity in the junction zone, interrupted junction zone. So to pick up early adenomyosis, we can use 3D, and also for locating the adenomyosis, as we saw in the presentation, it's very helpful for 3D. And sometimes we come across like a difficulty in differentiating between a myoma and adenomyosis. So in that case also 3D is very useful.
Okay, otherwise most of the patient you deal with 2D and Doppler.
Yeah, generally because we have a 3D, generally we combine both. And because we can take the uterine volume also by 3D. Because it's in the IVF center, uterine volume does matter before starting any FETs like.
Yeah. Good evening, Dr. Richa. And
hello, Asha ma'am. Hello.
Hi.
Nice to see you.
Dr. Padmashri, it was a lovely talk. But be honest and tell them that you do 3D for all the patients with adenomyosis.
That's what I told her.
Okay, I have seen the slides which had 2D and 3D both. All the
because
slides.
3D is like opening the eye fully. You see everything. Whereas with 2D, it is like a filtered image. You do not see the details. And whenever Padmashri does not do a 3D, we phone up and ask her, Padmashri, you forgot to do the 3D. And for infertility, it gives you so much detail that all cases of adenomyosis, we always do 3D, which is a fact. The machine is available, but without that machine, it is as if her hand will be broken. Tomorrow, if that machine fails, Padmashri will complain, saying that, ma'am, I'm not able to see anything. If you just give her a 2D machine, I'm sure she'll grumble. So what I'm saying is always do 3D for adenomyosis and endometriosis. You see much more. And many doctors refer it for MRI because they themselves are not able to do the 3D. And not everybody has the privilege of having a sonologist like Padma Shri, who always gives the accurate report. So in my center, maybe we do MRI only in 10% of the patients, not otherwise.
Yeah,
Everything can be read by 3D ultrasound.
That's right. People who are good with 3D do away with the MRI expenses also.
Because a normal ultrasound machine costs about 15 lakhs and a 3D ultrasound machine will cost 25 to 50 lakhs. Many people do not want to spend on this. So they would do whatever is available and send it across for MRI. So skill and machine, both the person and machine both have to be available.
Exactly. Yeah. Great talk, Dr. Padma Shri.
Okay, thank you.
Somebody said Padma Shri does not require a Padma Shri because her name is already Padma Shri.
Great presentation, Dr.
Yeah, very wonderful presentation. All our, I think, doubts were cleared. Nice videos and everything. Thank you so much.
Thank you.
Dr. Huma.
Thank you, ma'am. Thank you, ma'am, for making us understand such a complicated topic in such a beautiful and simple way and make us learn about the imaging in adenomyosis. Now, moving to our next session, I would like to call upon the chairperson for the sessions, Dr. Chandra Mansukhani. Ma'am is a senior consultant, endoscopic and robotic surgeon in the Institute of Obs and Gynae, Sir Ganga Ram Hospital. Ma'am is the president of ISOPARB Delhi Chapter. Ma'am had been treasurer in NARCHI, IAMS. She had been joint secretary of AOGD, secretary of NARCHI, vice president ISOPARB, and vice president in IAMS Delhi Chapter at present also. And our next speaker, next chairperson is Dr. Manju Khemani. Ma'am is the chairperson and infertility subcommittee of Infertility Subcommittee AOGD and past chairperson of Endometriosis Committee AOGD. Ma'am is ex-professor of Lady Hardinge Hospital, New Delhi, and she is the chairperson of, he had been the past chairperson of Safe Motherhood Committee AOGD. She had fellowship in advanced gynecology, endoscopy based in Bombay. She had been past president of DGF Central and review editor of Jogi. So over to you, ma'am, for the next session on medical management of adenomyosis.
Yeah, thank you, Dr. Huma. First of all, I say it was a wonderful session we have listening since I'm in after 6 o'clock. Now I invite Dr. Asha Rao to speak on medical management of adenomyosis best practices. Dr. Asha does not need any introduction. She is a managing director.
Starting my talk. I'll call later.
Is there any problem? Am I audible?
Yes, you are audible, Dr. Chandra.
Yeah. So Dr. Asha is Managing Director, Rao Hospital and Care, and she is one of the pioneers of the field of reproductive medicine in the India. And ma'am, Dr. Asha has written many papers in the national and international journals, and she is a recipient of President of India Gold Medal, and she has an interest in the infertility, high-risk obstetric, PCO management, endometriosis, and recurrent pregnancy loss management. So now over to Dr. Asha Rao for your talk.
You are muted, Dr. Asha.
Yeah. Thank you. Good evening, my dear friends. Very happy to be here today. Thank you for the kind words, Dr. Chandra. And thank you so much for having invited me here, Dr. Mala. Mala and me have grown friends over the last 2 years, I think, with the endometriosis. And it is lovely seeing many of you here, my dear friends, Dr. Ragini, and the stalwarts like Dr. Gujral, Dr. Sahoo. So very nice, vibrant session today. And today I'm going to speak on adenomyosis, medical management. I'm very passionate about adenomyosis especially because the disease is more than 100 years old, yet we have so many difficulties in diagnosis and disputes in management. So I think it is very important that we know how to diagnose and how to treat adenomyosis. Let me just start my screen. Yeah, the disease is more than 100 years old, yet we have difficulties in diagnosis and disputes in management. And it is a disease of severe dysmenorrhea, menorrhagia, and infertility. We can call it reproductive dysfunction. There is either recurrent implantation failure or recurrent pregnancy loss. So whenever you see these conditions, you should definitely hunt for adenomyosis and treat it. And it is a very important member of the Palm-Cohen group of etiology of AUB. Once again, if there is difficulty in managing AUB, one should again screen, look at your findings again and see whether the patient has adenomyosis. And world over, so many thousands of hysterectomies are done every year for adenomyosis, which is a benign condition. So it is time we diagnose it early, treat it early, and prevent them undergoing such major surgeries. And especially because today there is a large change in trend. The disease which was seen more in Paris women above 40 years is seen more and more in younger women and infertile women. And it's also seen in about 20% of infertile women less than 40 years undergoing ART. So with 2D, you will see adenomyosis like this, large, big adenomyoma. But today, you can see Padmashri has grown. I have seen a phenomenal growth over the last 25 years. She has been with us for 25 years and she has been doing 3D since 2013, ever since we got the first 3D machine, that is E8. So with 2D, you will see adenomyosis like this when they're big. No? Even a blind man can see that this is adenomyosis. But you need to diagnose adenomyosis like this. This is the early infiltration of junctional zone. This is endometrium, myometrium, junctional zone, and this is the small focal infiltration of adenomyosis. And this is also focal adenomyosis. So all of you, my dear friends, learn to do a 3D and diagnose adenomyosis at an early stage so that you can nip it in the bud and do not wait for it to become large and hit your eyes. And unfortunately, world over, there are no proper guidelines for managing adenomyosis. Now, all of us talk a lot, HRA, ACOG, Canadian Society, Royal College, FOXY, but we yet are to form guidelines for managing adenomyosis. If you ask me what is the right time to treat the patient, what should be the size of the lesion, which lesion do you do surgically, which lesion do you do medically, yet we have no guidelines, and it's time for us to start looking into this matter. And today in 2022, how do we treat adenomyosis? It depends on the symptoms of the patient. Is she a Paris woman or does she have a problem of infertility? Does she have dysmenorrhea, AUB? The various modalities available are surgical treatment, which is known to all of us, ART, and medical management. Surgical treatment earlier was hysterectomy, which was one-stop therapy, but today, since the women are younger, more and more adenomyosis, adenomyomectomies are being performed from almost 1952. But in spite of this, I would say 60 to 70 years, in spite of change in techniques, we still have a fear of a ruptured uterus during pregnancy. This is one reason we should definitely avoid surgery. And today we have fantastic medications which can give you very good results for fertility. And you can also suppress the disease and reduce the suffering of these women in terms of dysmenorrhea and menorrhagia. So it is high time we go into conservative management in the form of medical therapy. And this is a beautiful article in 2018 from Fertility Sterility, where our dear friends Silvia Venusini and Petraglia, he was the president of SUD last year. They have written a lovely article on medical management, where it is discussed about GnRH analogs, progestins, LNG-IUS, and combined oral contraceptives and NSAID, the various modalities, various effects and side effects of the medical management. And this medical management has anti-proliferative effect on adenomyotic lesions, increase apoptosis in the adenomyotic tissue, reduces the inflammation, and reduces the symptoms of pain, heavy menstrual bleeding, and infertility. The wonder drug of the decade, I would say, is Dynogest, which is a FDA-approved medication. It is a 4th generation testosterone. It's also a progestin. It is effective and well tolerated in the treatment of painful symptoms associated adenomyosis, not complicated by severe uterine enlargement or severe anemia. Because adenomyosis can cause on and off heavy bleeding, so it is not ideally suited for women who have severe menorrhagia. It has central and peripheral action. It can also cause anovulation, reduction of inhibition of gonadotropin secretion, anti-inflammatory, anti-angiogenic properties. Overall, it is very good for the treatment of dysmenorrhea, dyspareunia, chronic pelvic pain associated adenomyosis, although the GnRH analogs appear to be superior to Dinoges in controlling menorrhagia and for reduction of uterine volume. And 26% of women in Dinoges therapy had persistent heavy bleeding. This is one of the drawbacks of Dinoges. It is not so good with volume reduction, and occasionally patients can have the problem of persistent bleeding. But the good point is that it can maintain a very good average estradiol between 30 to 60, and it can prevent bone loss, at the same time cause suppression of the lesions and good reduction from the problem of pain. And long-term Dinoges treatment has been studied. We have had Visado study, which said you can use it for 52 weeks. And later we have had the Visan study, which has studied the usage of Dinoges for almost 7 to 8 years with minimal side effects. And you do not have the problem of bone loss. But occasionally the metrorrhagia is one of the problems. And Dinoges can also be used after the initial therapy with GnRH analogs. OCP, all of us talk that OCP is good. OCP is okay for dysmenorrhea. It can cause anovulation, amenorrhea, can be given, but it needs to be given continuously. Whenever you give it cyclically, it is of no use. But definitely LNG-IUS or Dinoges is superior to OCP. With 6 months of treatment for pain due to adenomyosis, the way VAS score decreases more pronounced in the Dinoges group, and it is very good in the reduction is very good in the GnRH group. And uterine volume reduction also is not so good with the COC. What about LNG? LNG-IUS has been our friend in the gynae clinics for almost 15 to 20 years now. It appears to be effective in relieving dysmenorrhea associated adenomyosis. It causes decidualization of the endometrium and adenomyotic deposits, can be used along with GnRH. It causes amenorrhea in 60% of patients in 6 months. And after any surgery for endometriosis also, you can use LNG-IUS for the associated adenomyosis. And almost 70% of the patients seem to continue it for 5 to 7 years. In fact, I had a patient who continued it for 14 years. At the end of 6 years, when I told her, come next year and let's remove your Mirena, she never came back. And she appears after 14 years because by the time the effect of medication had worn off and the dysmenorrhea was back. So we presented in Uofoxy as a tail of Mirena of 14 years. I have some other patients who have even continued it for 10 years. They say, no, ma'am, it's COVID year, do not remove it. Let me have it for 2 more years. So instead of 7 years, they have had it for 8 to 10 years. And earlier we thought it is not so good for women with moderate uterine enlargement. Today I have seen that uteri which are even 12 to 14 weeks, they do very well with Mirena. You give an initial dose of GnRH depot. I give 11.25 in women who have a large uterus. Then after 6 to 8 weeks, you introduce the Mirena. The chance of expulsion are much less. And there can also be a volume reduction by 10 to 23% by 1 year and better in 2 years. Side effects are sometimes weight gain, irregular spotting, breast tenderness, and headache. And you have to counsel the patient regarding this. And you can see that in our study of 153 patients of Mirena, almost half of them are adenomyosis and endometriosis, and 70% of them have continued for 5 to 10 years. You can use injectable progestins, but the breakthrough bleeding is a problem. And our dear friend Danazol, I would say that Danazol was a wonder drug in the 1980s. I remember this woman who was married for 16 years and she had married at the age of 18 years. So she was 34 when she came to us with infertility of 16 years and she had a globular uterus enlarged to 12-week size. This was 1992 and we had no gadgets apart from laparoscopy, which showed a bilateral corneal block with enlarged uterus. And all that we had was danazol. We gave her danazol 6 months because she had severe dysmenorrhea. At the end of it, when she stopped, within 2 months, she conceived spontaneously. And the girl child born in 1993, she got married last year. And it was a very happy occasion for all of us. But this wonderful medication lost its popularity because of the androgenic side effects. You cannot have women with hoarse voice, acne. So we had to stop using this medication. But today it is being tried in European centers in the form of intrauterine device or vaginal ring, or even a normal oral tablet can be used vaginally or rectally. So you can use the intrauterine device for 6 months, reduces dysmenorrhea, dyspareunia, pelvic pain, and no androgenic side effects, according to the study by Tosti et al. And this is an ongoing study in the Petraglia group in Italy. So this is the paper where they have the study by Petraglia et al. And even the vaginal ring has been used, but we need more RCTs. What about GnRH analog? It's a fantastic medication. And ever since, I think it's almost in 2006 that we started using this medication for adenomyosis. And we have enjoyed these good effects of GnRH suppression. GnRH analog suppress the gonadotropin secretion plus ovarian function, cause profound hypoestrogenism. It reduces the expression of aromatase cytochrome P450 in the utopic endometrium of women with adenomyosis and endometriosis. It reduces the inflammation, vascular endothelial growth factor, size of the lesion, and promotes apoptosis. But you definitely need progesterone add-back therapy to reduce the bone loss. New et al. Found that a long course of downregulation significantly improved the clinical pregnancy rate, ongoing pregnancy rate, and implantation rate in patients with adenomyosis. Same was supported by Tulandi et al. In 2019. After 2 to 6 months of GnRH analog, the mean uterine volume can be reduced from 180 ml to 80 ml. You can see this is reduction by almost 60%. It's fantastic. So why do you need a surgical adenomyomectomy when you can do a medical adenomyomectomy? And even if you're forced to do a surgical adenomyomectomy for some patients, you should use GnRH post-operatively for large uteri, and it can give beneficial result. So today I would favor medical adenomyomectomy and not surgical adenomyomectomy to avoid the chances of ruptured uterus. And anyway, after a surgery, you have to wait for 6 to 8 months in case of large uteri. And if it's a small focal adenomyosis of 2 to 3 centimeters, it's only an incidental surgery. It's not a surgery which is definitely indicated. This type of small focal adenomyoma can be suppressed by GnRH analog. You can do an embryo transfer and do not need to do a surgery. So this is a study by Matsushima et al., who showed a significant uterine volume reduction with GnRH analog group compared to low-dose estrogen progesterone and Dynogest after 16 weeks of therapy. Here you can see the uterine volume. With GnRH analog, before therapy, it was 307 cc. And after 16 weeks of treatment, it came down to 177. So it is a fantastic reduction by 50%. Whereas with low-dose estrogen progesterone and Dynogest, you can see the volume before therapy was 226, 232. And after 16 weeks also, it still remains 230 and 262. So in 16 weeks, the volume reduction is very minimal. So I would strongly support GnRH analog in women with infertility waiting for embryo transfer to use it for 6 to 12 to 16 weeks or even 6 months prior to embryo transfer and avoid surgery. The rate of euploid miscarriage is increased in the setting of adenomyosis. Even this form of recurrent pregnancy loss can be treated by using GnRH downregulation prior to embryo transfer. It boosts implantation. So it favors implantation, and it also decreases the chance of recurrent pregnancy loss. So which is a fantastic finding. This is one of our patients with subtle adenomyosis. This lady came with 2 failures elsewhere, and we realized that she had a posterior wall adenomyosis, not very large, it's subtle, you have to look for it. And then we gave her a GnRH depot. And at the end of 6 weeks, the suppression was minimal. But at the end of 12 weeks, you can see the mass is almost regressed. The endometrium is expanded. And we did an embryo transfer at the end of 16 weeks. She conceived twins and she did very well. So a lady with recurrent implantation failure did very well after a GnRH depot suppression of 16 weeks prior to embryo transfer. This is another lady who had prior IVF failure. She had a couple of laparoscopies elsewhere. And this lady came to us with a 4.7 centimeter bilateral focal adenomyosis. You can see here, it's quite tempting to operate. Whenever I present this in my panel discussion, everybody gets full. Yes, yes, ma'am, let's go for surgery. No, it's very tempting because there is also indentation of the endometrial cavity. She also had tiny chocolate cysts. But this lady, boldly, we gave her a suppression of 12 to 14 weeks. And after 14 weeks suppression, we did the embryo transfer. This lady has conceived a singleton pregnancy and the child is 3 years today. So I would definitely vote for GnRH suppression prior to embryo transfer. And this is one of our studies from 2000, up to 2014. Out of 56 women treated, we had 26 pregnancies, giving a 44% pregnancy rate. And miscarriage rate was 32%. So 65 to 68% live birth rate is very impressive in women with adenomyosis. Aromatase inhibitors. It's a old kid around a new block, we can say. No, it's an old medication, but today it is being recognized for its effect on adenomyosis and endometriosis. It's the second line of drug for endometriosis. It causes hypoestrogenism. It is good for pain relief, but it can also cause lowering of the bone mineral density. And in a paper by Badavi et al., 2.5 milligram letrozole, when used for 8 to 12 weeks, there was very good reduction in the volume of adenomyoma as well as improvement in the symptoms of adenomyosis. A combined use of aromatase inhibitor with GnRH analog gave a reduction in uterine volume by 60% in the paper by Kimura et al., which once again is a medical adenomyometry. My dear friends, use medical adenomyometry and not surgical adenomyometry. They also use letrozole. You have to use letrozole with norethistone once to prevent the formation of follicular cysts and also to prevent the bone loss. So kindly use letrozole along with norethistone. And this is the paper by Elnashar and Badavi, where they saw very good volume reduction. The green is letrozole and the pink is GnRH depot. Both almost had similar effect on adenomyoma volume reduction. This is one of our patients in the COVID year of 2020. She came to us in November 2019. She had, I think, one pregnancy loss earlier, and she also had an IVF failure elsewhere. She had a poor ovarian reserve, diffuse adenomyosis. Her uterine volume was 344 cc. The normal uterine volume is around 60 to 80 cc. So you can compare this to 12 to 14 weeks of enlargement, and you can see here the adenomyoma is 7.5 centimeter length. It's quite a large adenomyoma. ANA negative, karyotyping normal, male factor normal. So this lady, we went ahead and did the ovarian stimulation, collected the embryos, and we vitrified them. And then it was the COVID year. So February 2020, we vitrified the embryos, I think in January. And later in February, we gave her a suppression of 11.2 Yuliprist depot. And after 3 months, we gave her a second dose and then another dose of 3.75 suppression. So the suppression went on from 25/2 to September 2020. That's almost 7 months. She also had letrozole and norethistone along with that. The uterine volume came down to 204 cc. At this point in October 2020, with an embryo transfer, she did very well. You can see the large adenomyosis, and she conceived a singleton. During the 11-week scan, you can see a large adenomyoma in front. We were very much worried whether it could be reactivated and go in for preterm labor. Nothing happened. She did very well, and she had a term LSCS at 37 weeks. So if women come to you with infertility and adenomyosis, do a routine infertility workup, including measurement of ovarian function, semen analysis, treat them like anybody else. If it's a small adenomyoma, give them a chance for natural conception or do an IUI. Not conceiving, you give good GnRH suppression and do IVF, and many of them will conceive. If there's one failure, do not give up. You vitrify the embryos, suppress the adenomyosis again, and then do the embryo transfer. Most often, they will definitely conceive in 2 or 3 embryo transfers. If they have recurrent implantation failure, in spite of a very sincere and good suppression like we did, 6 weeks to 6 months, you can suppress. So in spite of this, if there is a failure, then it's worthwhile going in for adenomyometry, or if she has severe menorrhagia or dysmenorrhea not responding to medical management, go in for adenomyometry, not otherwise. So elagolix, all of us are ruling for this. It's a newer oral antagonist, FDA approved drug. You can use it up to 24 months. It can also cause BMD reduction with higher dosage, but it is very expensive and not available in India. So we have no experience. The drugs like esopristnil, Yuliprist can be used for dysmenorrhea. Mifepristol is being tried. I have not tried much of it. I'm not fond of it. Neutron artery embolization, if you compare to medical management, I would not recommend it for women with infertility. It is more for women who have completed their fertility problem because there is a high rate of miscarriage, low pregnancy rate, IUGR preterm delivery, PPH, and occasional ovarian failure. HIFU is being tried. So who will benefit from uterus sparing surgery in adenomyosis? Well-defined adenomyoma more than 5 centimeter, recurrent miscarriage or recurrent implantation failure after IVF, in spite of a good suppression. This is the only time you have to go in for surgery, not otherwise. I was very much upset last week when I heard a senior surgeon saying that adenomyosis, it is nonsense treating it medically. It does not respond. You should always do a surgery. I said, what size do you do a surgery? He said, more than 3 centimeter, I would go and operate. I said, not so, sir. See the statistics, see the data. It is time we change your mindset and go in for medical adenomyometry and not for surgical adenomyometry, because you can have 6% chance of uterine rupture. With previous cesarean, your chance of rupture is almost 0.1%. With previous myometry, your chance of rupture are 1%. Whereas with adenomyometry, the chance of rupture could be 6 to 8%. This is one reason you should definitely avoid surgery. And anyway, you have to spend a lot of money and wait for 6 to 8 months after the adenomyometry so that you do not get a rupture. So to conclude, I would say that adenomyosis is a challenging condition, but let us understand the disease, see what is the need of the woman. If it is a fertility problem, definitely treat them with good suppression prior to embryo transfer and they'll respond well. And if it is a gynec patient who has completed fertility, give her a Mirena. You can give a pre-Mirena GnRH suppression and they will respond very well. Mild adenomyosis you can treat with Dynogest and they'll all do very well. Thank you all for a patient listening.
Asha, it was an excellent lecture and I learned so many new things. Even I was not aware about the IUCD Denazole. So rather there was a question also from the audience and even I would like to ask you whether this is available in the India?
No, India it is not available. So it is being tried in the Petraglia Center in Italy. But they say that you can use the oral danazole vaginally and it will have the same results.
Whether you have any experience with the
No, I have not tried vaginal danazole.
Vaginal danazole.
No.
So same tablet can be used vaginally?
Vaginally. This is what I am told, but I have not tried.
For how long we can give?
You can try for 12 weeks, 14 weeks.
Okay.
And but again, long term, only the RCTs are required, you know.
And
so we are looking forward to the Petra, because in private practice, we do not have such a large volume where I can try all the medications. Like Dynogest, we are trying intrauterine device, we are trying GnRH suppression. So again, a fourth medication, you know, to do an RCT, I think we do not have that many numbers.
Okay. And Dr. Asha, even I would like to ask you whether you have a good experience with the letrozole and norethistron.
We tried this letrozole and norethistron in about 10 patients prior to embryo transfer. And in difficult cases, I would say 3 of them conceived.
So for how long you would like to give? We should.
This one patient that I showed you in the 2020, there's one lady we had suppressed from 25 February to September. So I would say almost 6 months of suppression. I would say March to September. So 6 months we suppressed her. Uterine volume was big, 340 cc almost, which is like a 12 weeks uterus with a 7 centimeter adenomyosis. My surgeon friend would have said, no, you have to do a surgery. But this lady responded very well. Uterine volume came down to 200 cc and she has done very well, no preterm labor. And one more lady, we did a combination of similar therapy along with intrauterine device because she also had polypoidal endometrium. So with GnRH, with the letrozole, GnRH, norethistron and Mirena. We had suppressed for 16 weeks and then she had a singleton.
No, Dr. Asha, what should be the dose for the letrozole?
See, in all the texts,
and the norethistron.
The dosage used by Badawi et al. Is 2.5 milligram letrozole. But somehow, in my experience, I want to use 2.5 milligram twice daily. When I gave 2.5 milligram, it was not effective. Whether our medication is different from their, no, we should not say that openly. But I always use 2.5 milligram letrozole twice daily and norethistron 5 milligram per day, once daily.
Continuous?
Continuous.
Without
because you
any
allow them
break.
to bleed, they suffer with so much pain and heavy bleeding. So it's not worth withdrawal. No? And every withdrawal, you cause a miniature hemorrhage in the lesion. So please give it continuously.
For 3 months to 6 months.
3 months to 6 months. Yes.
Okay. So that is
Some
wonderful.
patients we are suppressed in the minor adenomyosis, we suppress for 6 to 8 weeks. Focal adenomyosis, instead of removing it surgically, we treat it medically.
Okay.
So whereas larger lesions, definitely you have to treat it for 12 weeks to maybe 6 months.
Okay.
Depends on the size of the lesion. That's why I said there are no proper guidelines. Maybe another year we should understand something and should be able to tell people what is the size of the lesion and how much you have to suppress.
So Dr. Asha, it was wonderful and I really enjoyed. I think all the audience, they enjoyed your lecture and you gave us a very important tips. So thank you very much for excellent and crisp.
Thank you. Thank you, Dr. Chandra, for your kind words. And thank you, Dr. Mala and team for giving me this opportunity.
So thank you, ma'am, for enlightening us in such a beautiful and elaborative session on medical management of adenomyosis. Now we are moving towards the last session of today's CME, which is on surgical management of adenomyosis. For the session, I would like to call upon the chairpersons, Professor Mala Srivastava. Ma'am doesn't need any introduction as such, but ma'am is a senior consultant and head of gynae onco unit in Sir Ganga Ram Hospital. Ma'am had been ex-president in AOGD. Ma'am is the vice president elect for ISOPARB 2023 to 2024 session. Ma'am had been an awardee of ABJ Abdul Kalam Excellent Award of DGF, awardee of Dr. Subhash Mukhopadhyay Women Health Icon Award, and a Women Medical Professional Award. So there are many crowned to ma'am's feather. And the second chairperson for today is Dr. Sunita Kumar. Ma'am is the senior consultant in Institute of Obs and Gynae in Sir Ganga Ram Hospital. Ma'am has got special interest in endoscopy and advanced endoscopy and gynae laparoscopic surgery. So handing over the session to ma'am for the last session of the today's CM.
Thanks, Dr. Huma, for the kind introduction. It's my pleasure and privilege to invite the star speaker of the day, Dr. Punita Bhardwaj. She is the unit in charge, senior consultant, gynae endoscopic, Sir Ganga Ram Hospital, New Delhi. And she's been trained from Lady Harding, Kasturba Medical College, endoscopy training from UK, USA, Germany, robotic training from France, IRCAD, Strasbourg, and she's been doing exclusively gynae endoscopy for last 22 years. Over to you, Dr. Punita, for your excellent scientific deliberation on surgical management of adenomyosis.
Well, thank you, Dr. Mala, for those kind words. Thank you for including me in this amazing program. And Dr. Asha Rao, I don't know whether she is there or not, but you almost converted me into a physician.
Yes.
Yeah, I'm very much excited. Thank you so much.
Excellent. I think the credit does go to you, but I'll stick to my topic and I'll talk about the surgical management. Dr. Deepika, can you project my presentation, please? Dr. Deepika. My topic for the day is surgical adenomyometry. Adenomyosis per se, it's a word which sends shudders. You know, it reeks of pain, it reeks of discomfort, it reeks of a very low quality of life for the patient. And I think it's a very important topic to cover, which has a lot of lacunas as far as the general practitioner is concerned. You know, the moment you hear adenomyosis, you're bound to say, okay, hysterectomy, nothing can be done. Her fertility is almost over and let's get it done and over with. But lately, I think we are coming to very selective and conservative surgeries where we can preserve the uterus and the fertility of the patient in the form of adenomyomectomy. So the topic for me today is the surgical adenomyomectomy, and I will take you through some series of cases that we've managed surgically. Of course, nothing to say against medical management, but in a medical management, you don't give that option of pregnancy immediately. Of course, even in a surgical branch, you need to wait. So that's an adenomyoma, and I'm using vasopressin for reducing the hemorrhage during the surgery. And I'm trying to give a semilunar incision, posterior adenomyoma. And she's a young lady with, I think she's had 2 abortions. And this is not a very big uterus. So probably a medical management would do, but since she's had recurrent abortions, she's been trying medical management too. So what I did was, of course, we need to map. If you don't have a ultrasonologist who's as good as Dr. Padamshri, what you do is take out, if you don't have an ultrasonologist like Dr. Padamshri, you do an MRI, but otherwise you take out bit by bit all the pieces of adenomyoma. And this is not a generalized, but a localized diffuse adenomyosis. And what I'm doing is remove all this and then taking sutures. You realize I'm taking a vicryl and I'm taking a central suture, keeping it long, not tying it, because I need to obliterate the dead space. And to obliterate the dead space and to take the next suture deep within to prevent leaving a dead space, you need to tie it later, so that when you're taking the needle in the depth, you don't miss out the lowermost margin. The upper serosal layer is done by interrupted sutures, and you cover the layer with the Surgicel to prevent adhesions. That's a big adenomyoma. This was an unmarried girl and with severe pain, not responding to medical management, and a large posterior wall adenomyosis. It was not an adenomyoma. And I gave her a vertical incision. I am an ipsilateral person. Both my ports are on one side. Of course, you can have a suprapubic port also in these cases. And you can identify, even with the naked eye, the adenomyotic tissues and the normal pink myometrium. You see that? And here I'm using the V-lock suture, an excellent suture for cases like this, because if people in the audience who do myomectomies and adenomyomectomy, you realize there's a difference between doing a myomectomy and adenomyomectomy vis-a-vis handling of tissues. A myoma is much easier to enucleate than an adenomyoma because the distinctness between the myometrium and the adenomyosis is not there. And you have to be careful that you do not excise, and that's the endometrium there. You see that bulge there, that's the endometrium. And we are avoiding to take the endometrium. We are going as deep and as close so that the dead space is obliterated. And there is no hematoma. Its basic principles remain the same, that you enucleate, you remove as much of the diseased tissue as you can, and bring back all the tissues together to maintain the integrity of the organ so that she can go through the vagaries and the expansions of pregnancy without having ruptures, so to say. We quoted a high adenomyomectomy rupture rates. Of course, one has to be careful. One has to carefully do a case selection. One has to see that you don't excise normal myometrium excessively. You don't use too much of energy. You realize I'm using cold scissors. I'm not using energy in these cases so that I do not injure the remaining myometrium. And the serosa, like you see, will be stitched with interrupted sutures. I don't let the V-lock come onto the surface to prevent any bowel injuries or bowel problems, so to say. Literature has reported subacute intestinal obstruction with exposure of the V-lock to the bowel. And moreover, I cover the posterior surface with the Surgicel so as to prevent the direct adhesion formation or a posterior wall adhesion later on. One has to understand that there are comorbidities associated with adenomyosis. You can have fibroids with it. You can have endometriosis with it. And literature says that the recurrence rate with these associated problems is much higher than just having an isolated adenomyosis. So one has to watch out and manage these conditions along with adenomyosis, and that is the part of the tissue that is being excised, which is sent for histopathology examination. Of course, I am not debating the in-bag morcellation or, naked morcellation, so to say. And that's an endometriotic cyst on the left-hand side. Her POD was obliterated. So you excise, the pain element comes down considerably if you manage the endometriosis associated with adenomyosis. One has to be careful while doing a cystectomy, and I'm amongst infertility specialists, so not to reduce the AMH and remain in the tissue planes and not to destroy the ovary. I do not use sutures for putting back the ovary. If you are gentle with the ovary and you remove just the cyst wall, you approximate the ovary, hemostasis is achieved. Of course, you have to do selective cauterization of bleeders. Most of the time, these bleeders, if you are in the right planes, don't bother you with electrocoagulation. You don't need to bother too much about electrocoagulation. And so that the AMH levels are not hampered and the tissue of the ovary is not well, I do put a drain in these cases, because we don't want adhesions post-surgery, and drain is a good trick to release all the traumatized tissue oozes. I put it from the left lower port and take it out depending on the drainage that you have. You don't have to create an extra port for putting in a drain. I think it's a very good idea, and you know what's happening with the intra-abdominal environment. The next case. The next case. Yeah, that's another case of endometriosis with adenomyosis and a lot of bowel adhesions. The posterior pouch of Douglas is obliterated, and I use a suction irrigation to release the adhesions from the posterior surface. To create as close a normal anatomy before starting actually the process of adenomyometry in case you have adhesions, in case you have endometriotic cyst, and blunt tissue dissections will go a long way. Of course, I don't hesitate in using a sharp dissection. Once the vasopressin, how do you decrease the hemorrhage? Either you use vasopressin or you ligate the uterine arteries at the origin or the ascending. This is temporary ligation because fertility is a question. And here I'm giving a transverse incision, and taken out the wedge-shaped adenomyoma and closed the dead space. I agree that when you are doing a wedge resection, the corners are left, but that's okay. Every adenomyotic tissue need not be removed. You can reasonably, without compromising on the myometrial integrity, should be removed. And like I said, to prevent the posterior adhesions, you do cover your suture line with anti-adhesive. This was an amazing case. This was a referral to us, and the ultrasound said myoma. And when I got in and I saw this, I said it was a bad adhesion on the left-hand side with the tube, with the ovary all gone, all stuck badly to the posterior surface with the large bowel. Even the small bowel, I haven't shown the small bowel in this, and we've released all that. We've gotten to this state. And we've injected vasopressin to the tune of 10 units in 100 cc normal saline. Of course, before injecting vasopressin, you do warn your anesthetist that you are injecting vasopressin. And this was a huge 10 centimeter posterolateral wall adenomyoma. And patient was used to howl in pain, failed medical management. And there she was on the surgical table. And I'm using a 10 mm special tenaculum from the right, and it's a very good grasper. Normally, when you use a myoma screw, it tends to cut through, but this gives me a very good grip and I can change the grip easily. So I like this instrument. A lot of people use myoma screw, but that's okay. To each his own. The idea is to get a grasp or a hold on the adenomyoma and excise it. I'm using sharp dissection. There is no energy being used. I refrain from using energy, although it reduces probably your bleeding and probably the operative time. But I think in the larger good of the patient, it's okay to be a little more meticulous, a little more, particular about not using energy and to reduce the rupture rates. If you use too much of energy, a lot of time post myomectomy, the procedure was being blamed for ruptures, whereas it is the skill of the surgeon and other aspects also, of course, and the use of energy source, which reduces the scar integrity. The dead space needs to be obliterated well to prevent hematoma formations. Hematomas can lead to reduction in scar integrity, also infection rates, and increases the chances of rupture. And when you have a good approximation, when you have removed most of the adenomyotic tissue, you tend to have a good approximation of the tissue. You see that the whole bulge is gone there, and we got almost the entire adenomyoma, and the patient healed well. Of course, to reduce the recurrence rate, you need to give added medical management, GnRH, like Dr. Asha Rao said. And if you accompany the GnRH with the levonorgestrel or an OCP, the advantage is even doubled, they say. So it's a good idea to give medical management, post-surgical management, to improve the fertility rates. And of course, GnRH is also being used prior to the IVF cycles. So that adhesion layer is covered with Surgicel. On the left-hand side, I will put a drain in this. And I do give antibiotic. This is just to enumerate the wedges. You see this wedge that we remove? We leave the tail. When we remove this area, we leave the tail. This is the double flap method, where you have a sagittal incision. The yellow area is the adenomyosis. You excise the adenomyosis and you approximate. You get the myometrium here with the 20 or 30 vicryl, and you approximate the dead space here without leaving any chance for hematoma formation. This is the same flap method, double flap method. That was pictorial, and this is more real. So you have this flap inside in, and you have to remove the serosa before you get this flap over. It's a double flap technique. A lot of word has gone around with the double flap and a triple flap technique, where you can have increased enhancement of the integrity of the scar. This is the Osada triple flap technique. Again, you give a sagittal incision, open the endometrium, feel for the adenomyotic tissue here, excise the entire adenomyotic tissue, and then you close the endometrium, and then you approximate the layers on one side anteroposteriorly, and you get this flap over this. But after you approximate it, the serosal layer goes, so that only the myometrial and the myometrial tissue come together. Now, follow up and outcome. How do you measure the curative effect indices? Whether it's mild, moderate, or severe, depending upon the menorrhagia. And the dysmenorrhea index is measured with the visual analog scale. CA 125 level is also used for follow-ups, less than 200, more than 200. If it is less than 200, usually you don't get recurrences. And size of the uterus is measured by ultrasonography, volume A into B into C into 0.5, that is length, width, and thickness. Evaluation of the therapeutic efficacy is done by whether it's a complete remission. I'll just continue, Dr. Mala. Complete remission, significant remission, partial remission, no remission, or recurrence. So significant remission is pain score goes by 3 grades, goes down by 3 grades. And partial remission is that it goes down by 2 grades, and no remission is there is no change. And of course, recurrence is, even if you get a complete remission or significant remission, but dysmenorrhea recurred and aggravated progressively 1 year after operation, and the appearance of adenomyotic lesions was confirmed by ultrasound or MRI. So a partial remission, no remission, and recurrence was defined as clinically ineffective operations. And the follow-up is done by 1, 3, 6, and 12 months, and you measure by history, gynecological examination, and CA 125 levels. A lot has been talked about the rupture. Every adenomyomectomy doesn't rupture. Yes, it is important to know that the amount of excision that you do, the extent of excision that you do, the cold knife or the energy source that you use, the method of reconstruction of the uterine cavity and the wall, post-operative wound infection, hematoma formation, and the period of contraception post-surgery is very, very important. Now, I was reading about the period of contraception, and people talked about 3 months, 6 months, 8 months, 1 year. But I think you need to follow up the wound area with the vascularity. If the vascularity has come, you can give a go-ahead to the patient for conception. I think I'm taking too much of time. I would wind up with this. Adenomyomectomy, surgical adenomyectomy is a good armamentarium. And I'm not negating the medical management, but I think there is a place for surgical adenomyomectomy where you can give a conservative approach to a disease which was initially considered as a hysterectomy straight away. Thank you very much.
Very, very good video presentations, Dr. Punita. And you have done justice to your patients. Well, the indications for either medical or surgical treatment depends from surgeon to surgeon and doctor to doctor.
Absolutely.
But yes, you have very nicely stressed upon the need of indication for surgery. You know, one has to be very clear about the types of adenomyosis you're dealing with, and then decide whether you want to go for conservative treatment or surgical treatment. You know, like the videos you showed, adenomyoma is still relatively a little easier because of the well demarcated margins of the adenomyoma than a focal and diffuse adenomyosis. So if you take up diffuse adenomyosis, you definitely need advanced technique and proper say surgical good surgical sutures. Otherwise the chances of rupture is definitely high. So very nice videos. And well, the indications have to be very clear whether you're taking up surgery for pain, for the menorrhagia, or for infertility. And detailed counseling of the patients, if you take up the patients of infertility, about the consequences and the post-operative scenario, you have to stress upon the miscarriage rate, the placenta accreta, and definitely your most important mid-term pregnancy ruptures, silent ruptures, which you have very nicely stressed on, your surgical technique, the amount of muscle you damage, the amount of gap you leave, the amount of hematoma formation, you space for hematoma to form. Then if you form a hematoma, it infects, and then definitely the chances of rupture increases. So very well done. And then again, this time for contraception after surgery is again very debatable. The literature shows that even after people conceiving after 3 months do not rupture the uterus, and people are conceiving even after 12 months have rupture of uterus. So all this depends upon the amount of electrically powered instruments you use, the amount of excision. If you open up the cavity, well, all these go towards increasing the risk of rupture. And they say in rupture of a scarred uterus is definitely more than an unscarred uterus, coming from 0.005% in an unscarred to a 0.2 or 0.4% in a scarred uterus because of cesarean or myoma surgeries. But like Dr. Asha has very nicely stressed, the risk increases to up to 6% in post-adenomyomectomy surgeries, right? And well, you have stressed very nicely upon the vasculature, the angiogenesis after surgery. And you can have, you can look up on the ultrasound for angiogenesis and then tell the patient to conceive after 6 months. After 6 months, they say the angiogenesis does occur and the area becomes vascular. So the patients can go ahead for pregnancy, but very well done. And I would say that Dr. Asha and Dr. Punita both have done justice to their own field.
Thank you so much. No, Dr. Asha was amazing. She almost sold me and made me a physician.
So congratulations, Dr. Punita. Dr. Punita, it was an excellent lecture and excellent videos. There is definitely a place for adenomyomectomy. In fact, it was in 2009 that a lady who underwent 3 embryo transfers, 3 failures, we took her up for adenomyomectomy, and it was a 6 centimeter adenomyosis that we excised. And after 6 months, we did embryo transfer, and now she conceived twins, and she went to 36 weeks without any problem. And at cesarean, we could see that there was no indentation, there was no adhesion. We were very lucky. So,
in fact, we did for our colleague, our senior colleague, they're known to diffuse adenomyosis, 4 abortions, 3 IVF failures. It was a diffuse adenomyosis posterior wall, and we did an adenomyomectomy. Can you imagine? She conceived within a month spontaneously. And when I screamed at her, she says, "Madam, मेरे को तो conception होता ही नहीं था, तो मैंने contraception use ही नहीं किया." My heart was in my mouth. I said, within a month of adenomyomectomy, you can't do that. And her obstetrician continued the pregnancy. that this is a precious pregnancy. We
Yes, Dr. Punita, I think that was the best decision. We could not let that pregnancy go away.
So 2009 we did adenomyomectomy, Dr. Punita, but today with the more and more experience, you feel you can avoid so many adenomyomectomies because young surgeons are very, they're wanting a chance to operate.
No. It should not
that
be
is what we have to, the itch to operate is there in young generation. So that's what, they have to have a good rationale and good thinking.
Yes. Exactly.
Because I heard a senior surgeon saying that more than 3 centimeters, I would do a surgery, adenomyomectomy.
No.
Which is not correct.
Like you, yeah, that is exactly. You should not send a wrong message. It should you should tailor the.
Both are complementary. So whenever medical adenomyomectomy does not work, there is maybe a chance for surgical adenomyomectomy.
Exactly, I agree.
Excellent, nice discussion today.
I thank everyone, and I propose the vote of thanks. It's a pleasure and privilege to propose the vote of thanks. First of all, I thank Dr. Gangadhar Sahoo, the president of ISOPARB, who has spared his time all evening to attend this session and give us a pulse of wisdom. It's my pleasure to thank Dr. Ragini Agarwal, vice president of FOXI. She also gave us very encouraging words at the start of the session. It's my privilege to thank all the renowned speakers, Dr. Neeti Tiwari, Dr. Padma Shri, Dr. Asha Rao, and Dr. Punita Bhardwaj, who had given such excellent lectures, and we had been glued to the laptop right from the evenings till 7 p.m. And it's my privilege to thank all the esteemed chairpersons, Dr. Gujral, Dr. Deepti Goswami, Dr. Harsha Kullar, Dr. Richa Sharma, Dr. Manju Khemani, Dr. Chandra Mansukhani, and Dr. Sunita Kumar. And I thank all the audience who have been with us throughout the session, and they have given us courage and goodwill that so many people were logged in and seen our program. I must thank Dr. Deepika for giving us this platform from Jagsonpal, and my pleasure to thank Master of Ceremony, Dr. Huma Ali, who has been kind enough to agree to be the Master of Ceremony at the last moment. Thanks everyone. Good night and goodbye.
Ma'am, if I can take a few minutes, just like to introduce to all the audience and the faculty present today. Jagsonpal presents Dynogest 2 mg tablets as EndoReg. EndoReg has the longest shelf life of 3 years, and it is coming as a calendar therapy pack. Then we have Yuliprist acetate as Yuliprist, a very catchy name, and we are abiding by the DCGI approval that has been passed that it should not be used just for symptoms of uterine fibroids. It is indicated for intermittent treatment of moderate to severe symptoms of uterine fibroid only in adult women who have not reached menopause when uterine fibroid embolization and or surgical treatment options have not worked for them or are not suitable for them. So then you can prescribe Yuliprist acetate as Yuliprist, that is our brand name. And for freedom from menstrual irregularities, Jagsonpal presents CycloReg CR10 controlled release norethistron acetate tablets. Thank you all very much. And next from AOGD is the AOGD Delhi PG Forum, which will be on heart disease in pregnancy. That is on 18th of July. And the webinar ID is mentioned. This webinar ID can be accessed also from the Facebook link. Please do register and join in. Thank you all very much.